Hi everyone, we are from PBL 12 and today we would like to present case 4.
Mrs. E is a 35-year-old lady who was referred to us during her first pregnancy at 14-week gestation. Her modified oral glucose tolerance test showed a fasting level of 7.2 mmol per liter and 2 hours postprandial level of 13.2 mmol per liter. She has been married for the past 5 years and had 2 previous miscarriages in the last 3 years.
So our group came up with the diagnosis of gestational diabetes mellitus, which is characterized by impaired glucose tolerance and hyperglycemia during pregnancy. This also explains the previous miscarriages in the last 3 years. So based on the information provided, Mrs. E's fasting glucose and oral glucose tolerance test actually results in elevated blood sugar level outside the normal range, which according to CBT guidelines are fasting level more than 5.1 millimole per liter and 2 hours postprandial level is more than 7.8 millimole per liter. So we have chosen to give it insulin and oral antidiabetics, and insulin should only be initiated if the blood glucose targets are not met after medical nutrition therapy and metformin therapy. Human insulins are the preferred choice in pregnant women, while basal insulin analogs like detamir are as efficacious in pregnant women with gestational diabetes mellitus. So a basal bolus regimen used in conjunction with a healthy balanced diet can achieve tight postprandial glucose targets. For metformin, which is suggested in women who are in the first trimester, it should be offered if there is inadequate glycemic control with diet and exercise. Comparing with insulin, metformin was associated with less maternal weight gain.
So what are the effects of pregnancy on the childbearing woman with diabetes? Firstly, it can worsen the insulin resistance. HPL is released by the placenta and induces metabolic changes during pregnancy to support the maintenance of fetal nutritional status, causing increased insulin resistance. At around 16 weeks, insulin resistance begins to increase and decreases immediately postpartum. Next, increasing HbA1c levels are associated with adverse outcomes. However, due to physiological increases in red blood cell turnover during pregnancy and alterations in red blood cell kinetics, HbA1c levels fall during normal pregnancy and may not fully capture postprandial hyperglycemia. Next, what are the effects of maternal diabetes on child? So firstly, in the first trimester, maternal hyperglycemia can lead to diabetic embryopathy, for example, congenital anomalies including neural tube defects and cardiac abnormalities. In the second and third trimester, diabetic fetopathy can occur. So the baby's pancreas will continue to produce high levels of insulin in response to the maternal hyperglycemia as a compensatory mechanism. So this leads to fetal pancreas beta cell hypertrophy, which leads to fetal hyperinsulinemia. This can lead to fetal hypoglycemia after birth, and which can cause seizures, neurological deficits, and even stillbirth if it's not promptly treated. Fetal hyperinsulinemia can cause, firstly, decreased lung surfactant, leading to delayed lung maturation, which can cause acute respiratory distress syndrome. The increased glucose crossing the placenta can increase the fetal weight gain. And this can cause macrosomia, where the baby grows larger than average, which complicates the delivery by increasing the risk of shoulder dystocia and birth trauma, as the fetus has to go through the mother's cervix. So it will be difficult for the fetus to do so.
So that's all from us, PBL 12. Thank you.